Good day and welcome to the continuation of our discussions on breast diseases. Today we're talking about malignant disease of the breast, and this will be our final discussion on breast pathologies. The outline for our discussion includes case study, examination of the breast, then spread, triple assessment, staging investigations, staging, treatment, differential diagnosis, and references. Here's a case study of a history of a woman with malignant breast disease. So Mrs. Obi is a 58-year-old secondary school teacher with tertiary level of education who resides at number 3 Egan Street, Ekpoma. She's Christian and Isan. She presented to the consultant outpatient department with right breast lump of 6 months and right nipple discharge of 3 months. 6 months prior to presentation, she noticed a lump in her right breast while having her bath. The lump was initially small in size, about the size of a walnut, but has rapidly increased to its current size, which is about the size of patient's fist. There is no swelling in any other part of the body. 4 months prior to presentation, she noticed bloody nipple discharge. It was insidious in onset, seen initially only when expressed, but now comes out spontaneously. There is associated nipple retraction. There is no skin ulceration, no breast pain. She attained menarche at 14 years, had her first pregnancy at 25. She is multiparous with 5 children and breastfed each for an average of 12 months. There is history of use of oral contraceptive pills. She attained menopause at 55 years and she is not on any hormone replacement therapy. There is no family history of breast cancer, colorectal or ovarian cancer. There is no history of previous breast lumps in the past. Her diet consists of a typical African diet. She does not smoke, neither does she ingest alcohol. She has never been exposed to any form of radiation. There is no history of trauma to the breast. There is no chronic cough, contact anyone with chronic cough, drinking ice sweat or intake of unpasteurized milk. She has lost weight, and this is evidenced by loosening of previously fitted clothes and comments from relatives. Appetite is noticed to have reduced for previously enjoyed meals, and she experiences unusual weakness. She also experiences low back pain and lower limb weakness. No headaches, no fainting spells, no seizures, no chest pain, no cough, no abdominal swelling, no abdominal pain. There is no jaundice and there is no fever. She visited the general hospital in Ekpoma at the onset of nipple discharge and was referred to the specialist for expert management. She, however, delayed in presentation due to financial constraints. There is also a history of intake of herbal concussion. So this is the body of the history of a patient with malignant breast disease, where we talked about the biodata, the presenting complaints. We analyzed the presenting complaints and associated symptoms. We analyzed the possible etiologic risk factors, and then complications and care so far. So from this history, we've been able to take note of the possible risk factors for breast cancer. We'll talk more about it in the next slide. So risk factors for breast cancer includes increasing age greater than 35 years of age. The risk of breast cancer steadily increases with age greater than 35 years. And there is estrogen theory, which talks about increased periods of exposure to estrogen in a woman increases the likelihood of breast cancer, as estrogen is said to increase cellular proliferation and serves as a fuel for cancer cells. So early age at menarche and late age at menopause increases the period of a woman's exposure to estrogen. Early age at menarche is the menarche before 12 years of age, while late age at menopause is menopause greater than 55 years of age. Then late age at first pregnancy, that's age greater than 18 years of age, is also a risk factor. Multiparity and increased periods of breastfeeding are protective against breast cancer because it reduces a woman's exposure to estrogen and thus protects the woman against breast cancer. So nulliparity is a risk factor for breast cancer. Then use of oral contraceptive pills and hormone replacement therapy are sources of estrogen and are risk factors for breast cancer. Then there is the hereditary breast cancer. Here, certain genes have been implicated in the etiology of breast cancer, including BRCA1, BRCA2, PTEN, TP53, amongst others. Now, inheritance of these genes predisposes a woman to have breast cancer. It's important to note that women with hereditary breast cancer tend to present earlier than 35 years of age. They present at an earlier age, for example 30 years of age, and they tend to have bilateral involvement of the breast. It's important to note that 8 out of 9 women with breast cancer usually don't have a hereditary involvement. Then there is previous breast lump, which is also a risk factor, because a woman who has had a previous breast lump might have had a carcinoma, which increases her risk of having a carcinoma in the future. And then if she had a benign mammary dysplasia before, she's also at risk of having breast cancer. So previous breast lump is a risk factor. Then intake of saturated fatty diet, alcohol, and smoking, they are risk factors for breast cancer, although non-specific. This is a video on breast examination, so you just copy this URL to your browser and then the video will pop up. Thank you. So for spread of breast cancer, we have local invasion, lymphatic spread, and blood spread. For local invasion, infiltration of the lactiferous duct leads to retraction of the nipple. Remember that the lactiferous duct drains into the nipple. So when there is infiltration of the lactiferous duct, there is retraction of the nipple. The infiltration of ligaments of Cooper leads to dimpling over the skin covering the breast. For lymphatic spread, when there is infiltration of the dermal lymphatics, which drains the breast, there is lymphedema of the skin, because infiltration of dermal lymphatics may lead to obstruction and causing lymphedema of the skin over the breast, and it appears as pudorunge. Dermal lymphatic spread may give rise to secondary nodules seen on the skin of the breast and leads to carcinoma enchyraceae. I may not be pronouncing it well, but I'm pronouncing it as spelled carcinoma enchyraceae. Malignant infiltration of the axillary lymph node leads to lymphedema of the ipsilateral upper limb, because if the axillary lymph nodes are involved, the axillary lymph nodes are the nodes that drain the entire upper limb. So when they are involved, there will be obstruction to lymph drainage and to lead to lymphedema. For blood spread, commonly it spreads to the lungs, the liver, the bone, and the brain. For bony spread, malignant cells from the breast, they cause osteolytic lesions of the bone, so they demineralize the bone. We should take note of that. So triple assessment. When you see a patient in whom you are suspecting breast cancer, the assessment for such patients is regarded as triple assessment, including the clinical assessment, where you take history and examination, which we've just talked about, radiological assessment, cytological, and histological. For radiological assessment, commonly mammography and breast ultrasound scan is done. For mammography, is done for screening, usually for patients greater than 35 years, and then it's also used in diagnosing breast cancer. So in women greater than 35 years, is used in screening, and then women who are above 30 years with a family history of breast cancer, screening for them begins at 30 years of age. Now, if there is breast cancer, on mammography, it will show as loss of symmetry, architectural distortion, speculations, microcalcification, branchial calcification. Two views are usually taken, the craniocaudal and mediolateral oblique views. Mammography is better in women above 35 years because the breast has more fatty tissue than glandular tissue. I know as we age, the the glandular tissue of the breast, they decline and you have more fatty tissue. So opaque lesions are easily visualized with mammography in women who are greater than 35 years. For breast ultrasound scan, is better used in women less than 35 years of age because the breast is more glandular than fatty. So you would not want to use mammography for such women, because you will not be able to identify any lesion because everywhere would appear opaque. So you won't be able to distinguish if there is a lesion. So breast ultrasound scan is better for women less than 35 years of age. It helps to distinguish between cystic and solid lesions, localized impalpable lesions, and may detect some malignant features. Histopathological examination, or rather assessment, is done to assess the histologic type, histologic grade, presence of HER2 receptors and immunoreceptors. So presence of hormone receptors and immunoreceptors. A fine needle aspiration cytology is done, and depending on the facilities that are present, it may be able to show us cancer cells, but if not, only benign cells may be assessed using fine needle aspiration cytology. Then true cut or core biopsy is what is commonly done here, because it can help us to show the histologic type, the grade, presence of hormone receptors or immunoreceptors. Then wedge biopsy is done if there is a skin ulceration already. So if the cancer has ulcerated, a wedge biopsy is done. Then incision or excision biopsy can also be done. Then staging investigations. For us to stage breast cancer, apart from making the diagnosis, we have to know the extent of the disease. So a chest X-ray will help us to know if there's involvement of the chest. Abdominal X-ray will help us to know if there is involvement of the liver or if there are peritoneal seedlings. Liver function test also help us to know if there's liver involvement. Mammography or breast ultrasound scan of the contralateral breast is also important to help us to know if there is spread. Skeletal bone survey and bone scan are also important to help analyze for assess for spread. The common site of breast cancer metastasis includes the liver, the lungs, the brain, and bone. LLBB, that's the mnemonic to remember: liver, lungs, brain, and bone. So the staging of breast cancer commonly we have is the TNM staging, that's tumor node metastasis. So for the T, which is the tumor, we have tumor, that's TIS, carcinoma in situ. T0 is impalpable tumor. T1 is size less than 2 cm. T2 is 2 to 5 cm. T3 is greater than 5 cm, and then T4 is any size with skin or underlying tissue involvement. And then you have A, B, C. For A is when the muscle is involved, B is when the skin is involved, and then C when you have inflammation of the affected area, involved breast. Then for N, which is node, N0 is impalpable ipsilateral axillary lymph node. N1 is palpable discrete mobile ipsilateral lymph node. N2 is matted fixed ipsilateral lymph node. N3 is ipsilateral supraclavicular lymph node or lymphedema of ipsilateral arm. So N basically involves the ipsilateral side of the breast. So N0 is impalpable. N1 now is palpable, is discrete, is mobile. N2 is palpable but now is matted and fixed. N3 is that there's supraclavicular involvement or lymphedema of ipsilateral arm. Now M is metastasis. M0 is no evidence of distant metastasis. M1 is clinical evidence of distant metastasis. M2 is indeterminate metastasis. There is no clinical evidence and you need to do investigation to be sure. Treatment modalities. We have early, so based on the staging, we have early disease and late disease. Early disease is when you have T2, N1, MO, M0 and below, while late disease is T3, N2, M1 and above. So for early disease, usually surgery is the first line of treatment. So you do surgery first before you start cytotoxic chemotherapy, which will be adjunctive chemotherapy. And then if following your histologic assessment, the breast cancer is hormone or immune receptor positive, you institute your hormone therapy or immune therapy, then radiotherapy as a final modality. For late disease, you will not want to start with surgery because the disease has already gone far. It's not systemic already. So you start with cytotoxic chemotherapy, which is a systemic form of therapy because it goes around the system. Then you also institute hormone therapy, immunotherapy when the receptor is positive, and then radiotherapy just to downstage the tumor size, and then you can do surgery where possible. So for the surgeries, the two surgeries commonly done, we have mastectomy and then breast conservative surgeries. When the tumor has not involved the entire breast, you can still conserve some part of the breast. For mastectomy, you can do a simple mastectomy, do a radical hosted mastectomy. There is modified radical Patty's mastectomy. Then we have sentinel lymph node biopsy. In radical and modified radical, usually the axillary lymph nodes are removed. For sentinel lymph node biopsy, it's usually indicated when there is no clinical evidence of axillary lymph node involvement. So you want to know if there is lymph node involved when there is no clinical evidence. So it's done before axillary lymph node clearance. So before you do an axillary lymph node clearance with your surgery, you want to be sure that the lymph nodes are involved. Now, certain ways have been established to find out if there's sentinel lymph node involvement. A methylene blue or radioisotope albumin is injected in the subdermal lymphatics around the nipple period. For methylene blue, you inspect the axilla to see if the sentinel lymph node drain blue color, and that's positive. For the radioisotope albumin, you assess using the gamma camera. If you see involved lymph nodes, then it's positive. But usually, sentinel lymph node biopsy is not commonly done because you would already have removed the lymph nodes. That's during the radical surgery and modified radical surgery, axillary clearance is usually done to remove those lymph nodes. So sentinel lymph node biopsy is commonly not done in our environment. Now for chemotherapy, there are various agents for chemotherapy. There are various regimens because you have to combine more than one chemotherapy to form a regimen. We have the cyclophosphamide adriamycin 5-fluorouracil regimen. There is cyclophosphamide adriamycin regimen. There is cyclophosphamide methotrexate 5-fluorouracil regimen. Then taxanes can be given as monotherapy or added to the above regimen as a replacement for adriamycin. Usually 6 courses are given for 6 cycles. Hormonal therapy is also instituted for hormone positive tumors. Tamoxifen is used if patient is premenopausal, given 20 mg daily for 5 years. Aromatase inhibitors, example is anastrozole, is used if postmenopausal because tamoxifen increases the risk of endometrial cancer in postmenopausal women. Immunotherapy uses trastuzumab, also called Herceptin, if the tumor is immune receptor positive, or rather if the cancer is immune receptor positive. Then radiotherapy is given in small doses over the chest after mastectomy in selected patients in whom the risk of local recurrence is high. It's given for 5 days in a week, spread over 6 weeks, and then other parts of the body are covered with a lead impregnated agent. Only the part of the chest wall is that you want to give the radiotherapy is exposed. And differential diagnosis of breast cancer includes fibroadenoma, phylloides tumor, intraductal papilloma, duct ectasia, traumatic fat necrosis, chronic breast abscess, breast cyst, lipoma of the breast, Mondor's disease, tuberculosis of the breast. And intraductal papilloma because of the bloody nipple discharge, because intraductal papilloma is a benign condition of the breast with bloody nipple discharge. References: Clinical Surgery Tutorial Manual by Dr. Ernest Udefiagbo, and also the video we just watched was also by Dr. Ernest Udefiagbo. Then Bedo Textbook of Surgery. Thank you very much, and I hope you learned from this video. Thank you, and see you in our next video.